Hi, good afternoon, good evening, and some places, good morning, everyone. Uh, Thank you for joining us for the launch of this brand new webinar series focused on case-based discussions in spinal deformity. I'm Dr. Zeeshan Sardar. I'm a spine and scoliosis surgeon at the Ox Spine Hospital in New York with the Columbia University and New York Presbyterian Hospital. I am extremely excited to be co-chairing this series along with my partner and mentor, Dr. Lawrence Lenke. I'm just going to present this really quickly. I don't think we have a lot of time for discussion, but this is just to drive home one single point here. Here are my disclosures. So this is a 14-year-old female I've been following for a little while. The X-rays in front of you. The mean thoracic curve is about 52. This has been progressing over the course of the year and a half or so. So at this point, we decided on surgery. And I really wanted to show the coronal and the sagittal for this patient. Again, it's a bit different from some of the other cases we have seen, smaller Cobb angle of thoracic spine, but the lateral is more kyphotic than the others that we have seen. It's not as the others that we have seen really have been lordotic. This one has more of a normal, maybe a bit on the higher side as far as the thoracic kyphosis is concerned, but the MRI scan, everything else was normal. And maybe I'll ask you guys to comment on how does this change your level selection for this young patient? Maybe Feroz, if you wanted to take a quick jab at this, and then we'll move forward.
Yeah, I mean, looking at this, it's in my opinion, I mean, it's still a length one. I mean, that lumbar curve looks pretty darn flexible down to 20 degrees. I mean, they are numbers in the end. And then for kyphosis, if you blow it up at the thoracolumbar junction, if it is kyphotic, I'll go a little bit lower. And this is one that, the sagittal stable vertebrae line may be something worthwhile to draw up to see where you want to end. And I think we get burned by just looking at that, last substantial touch of vertebrae. And you can also argue, yeah, good for you. So you could argue that if you went to T11, T12, you could get burned with DJK. And I do think that DJK, as much as we've all chatted about PJK, DJK is a real concern, and we're trying to figure that out. Oh, so there you go. That's what you did. Great.
That was perfect. SSV, make sure you pick it up. The hard part is when that turns out to be the apex of your, a much more substantial lumbar curve, and you're trying to figure out what to do. But with a 42-degree curve, and you did a great job. Yeah, spin it back around. Nice one.
Yeah. That's the point. Is that fellows, I make always draw the CSVL and PSVL every single case you do.
Everyone.
You're gonna have it. At least do it. Do it in real, or do it in your mind. But always do that in every single case you do, because you don't want to ever miss this.
Oh, perfect. I'll show you the X-rays. And the other reason we called it a Lenke too was because the proximal thoracic kyphosis is high as well. So that makes the proximal thoracic curve structural.
Okay.
Yeah, that's it.
Good point.
Sorry, Larry. I'm gonna stop. So far so good. Everything looks good. We're gonna stop my talk here. I appreciate everyone's discussion. I think we had a lot of good discussion, drive some key points home. And that was the whole point of it, was to kind of have a case for discussion, so we can really discuss some of these fine nuances and fine points, and hopefully people learn from us, including us. Thank you again, Doctor, for joining on this discussion on AIS. Dr. Lenke, any final points, final comments?
Oh, hour went fast, Zeeshan. Great job. I think, and thanks again to everyone participating. We really appreciate it.
Great show.